Hey guys, it's John Adamson, the rehab documentation guru, and I am driving, and I'm going to try to do two things at the same time, which is something that guys have a hard time doing. And I wanted to make a video about this for a while, and it's a compliance slash ethics slash skilled services rant of some sort. And a lot of companies right now are facing huge amounts of denials from Medicare. And if you have any inkling about the denials you're getting, you might feel that Medicare just has it out for therapy providers. And that is partly the case. And I will say that we are mostly to fault. And I'm not just talking about the individual therapists, who I've met a whole lot of therapists across the nation and really good people. But the way the companies operate and bill for therapy services and the way they push their therapists. And I just wanted to talk to you for a moment about that. If you're in an entity, a company, that's billing for Part A services, and I'm talking about inpatient, where you get reimbursed for the amount of care you deliver per day. So it's a fee-for-service type setting, whether it's a rug situation in a SNF, or even inpatient rehab where you have a minimum number of hours per day that the patient needs to have therapy. I believe that we have contributed to the problem that we're facing right now, where Medicare is cracking down very hard on the therapy reimbursement industry. And it's because we've delivered services beyond the needs of the patient, that services that they did not probably need the level of care they received. And they probably could have gotten services at a less restrictive care setting that would have cost Medicare and other third-party payers less money. So in effect, we have overbilling. Now, therapy has contributed to the fact that it is estimated approximately $750 billion per year is wasted in Medicare, or I should say healthcare expenditure. Wasted. Now, that's obviously not all therapy, but we are part of the problem. And so let me just put a few things to you, this kind of rant, to help you perhaps be a part of the solution to the overspending and the targeted audits that therapy receives. And we'll start with Part A first. Gone are the days where we can maximize the patient's length of stay, their rehab reimbursement, and I think mostly the SNF world that I'm in, the rugs, rehab ultras, 100 days of Part A services per year. That's their benefit. It's the problem is this. There's probably not a lot of patients that truly need rehab ultras out there, unless they're getting 3 disciplines of service. I mean, there are cases where a patient benefits from rehab ultra with 2 disciplines, but it's probably going to be a fairly short time. One of the things I see, and I've talked to a lot of therapists in different companies, is they will max their rugs on patients who probably could have gotten away with a lot less therapy, because the issue is skill. So let's say you're 2 disciplines, seeing somebody rehab ultra, 72 minutes average per day, 5 days a week. Is it really necessary that the patient gets 72 minutes from you 5 days a week? And I've looked at enough documentation in the course of 9 years to tell you honestly that is not the case. So much of what we do with a little bit of training of a non-skilled person could be taken over by somebody else and taken care of safely and effectively with less money expenditure by the third-party payer and or less days of the patient being in our facility. So we have contributed to that problem, because partly we are, some therapists feel pushed to, keep patients on caseload because the facility wants the patient to have a last covered day of such and such, or their manager is saying, how can we get to a rehab ultra? And so they're pushing for as many minutes with that patient as they can. And I'm just urging you as a clinician, does the patient really need that? Ask yourself that honestly. And if you can honestly say, no, they don't need quite that much therapy, then you shouldn't be delivering it. Yes, are you going to get pushback? Yes. Could you be missing opportunities to treat the patient more? Maybe you are. Maybe there was more stuff you could do to fill out those minutes that would, honestly get a rehab ultra. But you got to ask yourself, do they really need it? So look at your caseload. Think about your patients. Do they really need all the therapy they're getting? And for Part A, that is one area we're seeing a lot of claim denials going on. For Part B, which a lot of you treated, whether it's in a SNF or an outpatient setting or an ALF, you have to ask yourself, do you need to see the patient 3 days a week? Does every treatment need to be 60 minutes? When you get close to discharge, are you going to keep them on 3 days a week? I see a lot of Part B claims, probably the vast majority, where the patient's seen 3 days a week, 3 or 4 units of care right up to the day of discharge. And you got to think about, in Part B settings, every intervention you do is a separate intervention, and it doesn't necessarily have to do with the other interventions. So for example, you're doing neuromuscular reeducation for balance, and then you're doing some E-stim for pain. Those problems, the balance and the pain, are probably going to resolve at different rates. And so as you get close to discharge, one of those treatments is probably going to go away. And so do you really need to see the patient Part B 3 days a week for 4 to 5 interventions or whatever you're doing? And generally, you should have a tapering dosage of the patient. So over time, less frequency and less interventions. So in summary, and for those of you that have actually watched this little bit of a rant, thank you for putting up with it as I do the impossible as a guy driving and talking at the same time. Number one, look at your patients and determine, do you really need that much intensity? If you're in a Part A inpatient setting, inpatient rehab, SNF, the goal is to get them to the next level of care as quickly, safely, and effectively as possible. It's not to maximize their days at all. It's to get them ready for transition to the next level of care, which might be home health, outpatient, ALF Part B, SNF Part B, whatever that might be, and a less intensive dosage of therapy. If you feel like you're always being pushed to keep the patient longer, to get them at a higher rug level, whatever it might be, put your foot down if you know the patient doesn't need that. Be part of the solution to reducing the reimbursements that have gotten us such a focus by Medicare and put us in their crosshairs. For Part B, one of the biggest things you can do is look for opportunities to taper the dosage of therapy, to wean the patient off of you, which really is good practice anyway, because you're trying to give basically the patient and or caregiver autonomy when you get done, when they get done with you. And so they're not going to get autonomy just like that when you're finishing up 3 days a week and haven't altered your frequency at all or the amount of care that they're given. So just think through those things. And that way we, as an entity, therapists, can help solve the problem of overspending on healthcare services in these United States. Anyway, I'm about home now. John Adamson, the Rehab Documentation Guru, and I appreciate you watching. Take care.